Welcome back to the Deep Dive, where we take these really complex clinical pathways, stacks of research, and sometimes, frankly, terrifying topics, and we try to distill them into clear, actionable knowledge for you.
And today, we are tackling a topic that, it's a 10 out of 10 on the parental panic scale. We're talking about the pediatric febrile seizure.
Right. When a child starts seizing, I can only imagine the terror is it's immediate, it's overwhelming.
Absolutely. But our sources, and we're pulling directly from the clinical guidelines of major institutions like Johns Hopkins, Mayo Clinic, CHOP, the experts, they all anchor on one single critical piece of data.
Which is
The outcome is overwhelmingly benign.
overwhelmingly benign. That is the crucial anchor point, and we really need to hold on to that. We're talking specifically about seizures triggered just by a fever, right? Not from some other underlying neurological issue.
Exactly. And our mission today is to cut through that, that initial wave of fear and confusion and just deliver clear, evidence-based safety, first aid, and management protocols.
So what to do in the moment, and just as important, what doctors are looking for in the hours that follow.
Right. But first, let's define the scope. This isn't some super rare condition. It affects a pretty significant population, somewhere between 2 and 5% of all children.
2 to 5%, that's a lot.
It is. And the age bracket is relatively tight. We're typically looking at kids between 6 months and 5 years old. And the trigger, by definition, has to be a fever, specifically a temperature of at least 100.4 Fahrenheit or 38 Celsius.
Just knowing that the incidence is that high, but the outcome is so good, it really does change the equation.
It does.
The data shows that these seizures, especially the most common type, have absolutely no long-term impact on intelligence or development.
None. No impact on intelligence, learning, or development. It really transforms what feels like a catastrophic event into what is actually a manageable, if frightening, medical occurrence.
So it shifts the whole focus from long-term fear onto immediate critical procedure. Okay, so let's unpack this. If you are there, and it is happening, that adrenaline surge makes following any kind of instruction incredibly difficult. So let's slow this down and really focus on the moments that matter most, the immediate safety protocols.
The first goal is simple. It's just safety and airway management. And the guidelines break it down into 4 steps that every caregiver should, try to internalize. They're designed to be achievable even when you're in a total panic.
Okay, lay out those 4 steps for us. What's the sequence?
Step 1, prevent injury. So you gently place the child on a flat, soft surface. The floor is perfect. And then critically, you clear away any hard or sharp objects nearby.
Because they might be flailing, but you don't hold them down.
Right, you absolutely do not restrain them. Trying to hold them still can actually cause an injury.
Got it. Safety first, no restraining. What's next?
Step 2 is positioning. This is a non-negotiable for protecting the airway. You immediately roll the child onto their side.
Recovery position.
The recovery position, exactly. It lets saliva or any possible vomit drain out of the mouth, which prevents choking.
Okay, and step 3. This gets to a myth that I think causes the most misguided panic. We've all seen it in movies, this idea of protecting the tongue. What are our sources saying?
This is the single most dangerous myth we have to bust. Step 3 is about airway safety, and the instruction is crystal clear. Loosen any tight clothing around the neck, but do not, under any circumstances, put anything in their mouth.
Nothing at all.
Nothing. A child cannot swallow their tongue during a seizure. That's a myth. But if you put a spoon or your finger in there, you risk all sorts of major complications. You could cause choking, break teeth, injure their gums.
Wow. So the risk of putting something in is way higher than the risk you think you're preventing.
Infinitely higher.
Yeah.
And the final critical step, observation. You need to become a silent, focused witness. Start timing the seizure immediately, from the second it starts to the second it stops, and then watch the movements. Try to see if it's the whole body shaking, which is called generalized, or if it's just one arm or one side of the face, which is focal. That information is vital for the doctor.
It's amazing how simple those 4 steps are. Side, clear the area, time it, nothing in the mouth, but in that moment of adrenaline, I'm sure it feels impossible.
It does, but taking those steps is how a caregiver regains some control. You shift from fear to task execution.
So we've done those steps. The child is safe. The clock is running. When does this move from first aid to a 911 call? What are the hard criteria?
Okay, there are several non-negotiable criteria. The most critical one is duration. If the seizure lasts longer than 5 minutes, you call 911.
5 minutes, that's the key cutoff.
That is the key clinical cutoff for when the event might need medication to stop it.
And what are the other red flags?
If the child has obvious trouble breathing, or if they turn blue in the face, that's an immediate life-threatening emergency. Also, if the seizure movements are focal, so just one part of the body, or if the child doesn't recover quickly afterward. If they seem very ill or have a stiff neck, lethargy, excessive vomiting.
And one point the guidelines are really firm on. If this is the child's very first febrile seizure, you call for help regardless of how long it lasts.
Yes, absolutely. That initial evaluation is essential. You need that first assessment to confirm that it is a simple febrile seizure and to rule out other more serious causes. You don't have a history to go on, so you have to be cautious.
That moves us really neatly into the next big question, because managing the fever itself is where a lot of that old conventional wisdom really crashes headlong into current evidence. I think this is where it gets truly fascinating.
It really is. This is the major conceptual shift we want you to absorb from this deep dive.
We've all been conditioned to fear the high number on the thermometer, but the evidence says aggressive fever management doesn't even help prevent another one.
Exactly. The consensus has moved from what we call aggressive management to comfort management. Those aggressive methods like, rapidly alternating acetaminophen and ibuprofen or using tepid sponge baths, they've been studied thoroughly.
Yeah.
And they provide zero additional benefit in preventing another febrile seizure. Zero.
That is genuinely counterintuitive. If the fever triggers the seizure, shouldn't lowering the fever stop it?
The science here is key. The seizure isn't triggered by the fever peak, but by the rapid rate of rise in temperature.
So how fast it goes up, not how high it gets.
Exactly. And this rapid rise often happens at the very beginning of the illness, sometimes before a parent even notices the fever or before any medication could possibly take effect. Once that neurological cascade is triggered, trying to chase the number down is just too late.
So what about fever reducers then? Things like Tylenol or Motrin acetaminophen and ibuprofen, we should still use them, but the goal is different.
Absolutely. The goal is comfort. They should be used to make the child feel better, to ease the muscle aches, the headache, the fussiness, and importantly, to help them feel well enough to drink fluids and stay hydrated. We're treating the distress from the illness, not the risk of a seizure.
Because the meds just don't prevent recurrence.
They do not.
So if medication doesn't prevent another one, what about long-term meds for kids who've had one? Do they need to be on daily anticonvulsant drugs?
No. The guidelines are very firm on this. Routine, long-term anticonvulsant prophylaxis is not recommended for simple febrile seizures.
And that's a risk-benefit calculation.
It's a classic risk-benefit analysis. The potential side effects from daily anti-seizure drugs are significant, and they far outweigh the minor benign risk of having another febrile seizure, which, as we said, has no long-term developmental impact.
Makes perfect clinical sense. Don't trade a self-limiting event for the risk of serious drug side effects.
Which brings us to the next stage, the medical assessment. This is where doctors differentiate between simple and complex seizures because that distinction dictates the entire diagnostic path.
And the main thing for clinicians in the ER, no matter what, is to rule out something much more sinister, right? Like a central nervous system infection, meningitis.
Exactly. Everything hinges on that initial clinical assessment. The history, the neurological exam. They're looking for any sign of that one rare exception where a serious infection is the cause, while also protecting the vast majority of kids from unnecessary tests.
Okay, so let's break down the definitions. Simple versus complex.
Simple febrile seizures are the vast majority. We're talking 70 to 80% of cases. And they have three key features. Duration less than 15 minutes, generalized involvement, so the whole body is shaking, and no recurrence within 24 hours.
And a complex seizure just needs to break one of those rules.
Just one. It's complex if it lasts longer than 15 minutes, or R has focal features like just one arm shaking, or if they have 2 or more seizures in 24 hours. If it hits any one of those markers, the level of medical suspicion goes up.
And this distinction leads to a really striking difference in the required workup. This is the good news for parents, I think.
It really is. For a child with a simple febrile seizure who looks well and is back to their normal self, routine testing is not recommended.
So no routine EEGs, CT scans, MRIs, or blood tests.
Correct. The evidence is clear that they're not necessary and just expose the child to unnecessary intervention and anxiety.
That's powerful reassurance. But what about the lumbar puncture, the spinal tap to check for meningitis?
The need for a spinal tap is also highly selective. For a simple febrile seizure, an LP is only considered if there are specific risk factors.
Like what?
For example, if the child has meningeal signs like a stiff neck, or if they're in that 6 to 12-month age range and have incomplete immunizations, or if they were recently on antibiotics that might be masking the symptoms of meningitis. It's a targeted tool for high-risk subsets only.
A rifle, not a shotgun.
Oh.
And for complex seizures.
For complex seizures, the testing is more selective and based on clinical judgment. It might include blood work, maybe a head CT if there's suspicion of a focal issue, or an outpatient EEG. But even then, doctors are urged to avoid the full battery of tests unless it's really justified.
Okay, let's go back to the acute setting. If a seizure does go past that 5-minute cutoff, what happens then? What's the intervention to stop it?
So if it persists longer than 5 minutes, that's defined as status epilepticus in this context, and rescue medication is necessary to stop the seizure. This means fast-acting benzodiazepines.
Okay, like what? And why are there different ways to give it?
In a hospital, they'd use an IV for lorazepam or diazepam because that's the fastest route. But for kids with a known history of long seizures, a doctor might prescribe rescue meds for parents to use at home.
And parents can't give an IV.
Right. So in those cases, the formulation is often something like rectal diazepam or intranasal midazolam. They're crucial because they offer a rapid way to stop the seizure outside of a hospital.
Wow, that is intense. To be entrusted with that kind of medication at home, it really speaks to the priority of just stopping a prolonged seizure quickly.
It does.
So what's the long-term outlook for these children?
The prognosis is excellent. The vast majority of kids just outgrow it, but recurrence is common. About a third to a half of children who have one will have another during a future illness. The risk is higher if their first seizure was before 18 months of age.
And the big fear, the risk of developing epilepsy, a non-fever-related seizure disorder.
It remains remarkably low for children with simple febrile seizures. We're talking about 2%, which is barely above the risk for the general population. The complex cases carry a slightly higher risk, but it's still very manageable with follow-up.
And once the seizure is over and the workup is done, what are the criteria for a safe discharge from the hospital?
The child has to be completely back to their neurological baseline, acting like their normal self. They have to look well, be tolerating fluids, and the source of the fever needs to be identified and manageable at home, like a simple ear infection. And most critically, the parents have to be thoroughly educated on seizure first aid.
This whole deep dive has been incredibly clarifying. It's taken this terrifying event and broken it down into a sequence of manageable steps. If you had to distill this down to the 2 most important takeaways for a listener, what are they?
First, master those 4 immediate first aid steps. Remember the positioning on their side and the absolute non-negotiable rule to never put anything in the child's mouth. That is the difference between panic and safety.
And the second point, about the follow-up care.
Second, really understand the role of fever control. Those medications are for the child's comfort, for hydration. They are not a tool for preventing the seizure itself. Shift your focus from chasing the number on the thermometer to keeping the child calm, cool, and well hydrated.
So when we synthesize all this, what does it all mean?
What's so fascinating here is the dichotomy. The seizure itself is often harmless, brief, and benign, no lasting impact. But the robust, methodical evaluation process that the clinical pathways demand, that is absolutely critical.
No.
Because the goal of the medical intervention isn't just treating the seizure, it's making sure that a life-threatening treatable cause, like bacterial meningitis, is definitively ruled out. The diligence is for the rare exception, and that protects the many.
That connection, the benign nature of the symptom versus the critical need to rule out the serious cause, that makes all the medical thoroughness make complete sense.
It does. And that diligence raises an interesting question about modern home management that we touched on.
The rescue medications.
Yeah, the rescue meds, the rectal diazepam or nasal midazolam prescribed for home use in rare, high-risk cases. It makes you wonder, how does the responsibility of caring and potentially using such a pertinent medication at home influence parental anxiety? It changes the family dynamic entirely, It places this serious medical tool right next to the bottle of ibuprofen, even for a condition that is in itself largely harmless. It's just a profound thought on where medical necessity and anxiety intersect.
A perfect encapsulation of the human element in clinical management. Thank you for guiding us through this. It was challenging, but ultimately, I think, very reassuring.
My pleasure.
We'll catch you next time for the next deep dive.